All right, welcome everybody to the October Grand Rounds. I want to thank you all for what you've been doing and your forbearance. This has been a shutdown like none other on several different levels, but we have been steadily ramping back up to what we were doing, and we finally got permission to do this. So thank you very much for attending Out of Cycle. I'm sure Christy or Deanne will go over the rest of the Out of Cycle as we get through the holidays, but our goal is to get us back on a pretty even keel. Um, as far as airman certification, for the first time in all of the shutdowns I've been through, airman certification was an accepted function. It took us a minute to get things back up to full speed and get everybody recalled. But again, we appreciate what you're doing and your dedication to the safety of the national airspace. So without further ado, what you really want to hear is what we have to present. So Christy, back to you.
Thank you, Dr. Northrup. I'll echo Dr. Northrup's statements. Thank you all for being here today and joining us for this session of Grand Rounds. As always, we have just a few housekeeping items to go over before we jump into the content of our presentation. First and foremost, this session is being recorded. No participants will be shown on camera, and the recording will be made available later on the FAA AME Guide YouTube channel. I can't tell you exactly when that's going to be loaded. Obviously, due to the shutdown, things are a little bit behind the schedule, but we will get that loaded as soon as we can. The easiest way to find our YouTube channel is to just open up your favorite browser and do a search for FAA AME Grand Rounds, and that should take you right to the YouTube playlist. Keep in mind, if you're watching the recording or any of our recordings of Grand Rounds, that those Grand Rounds were current as of the month that those were presented. Rules of engagement for the session. The Zoom room will be locked after 10 minutes. And what this means to you is that once I've finished my spiel and we've started into the content of the presentation, if you drop out of the Zoom, you may not be able to rejoin the Zoom. You could possibly email Dr. Deanne King at deanne.king@faa.gov, and we may be able to readmit you, but due to all of the technical stuff that goes on behind the scenes, just keep in mind, if you drop out, we may not be able to let you back in. Also, chat and your cameras and the ability to unmute yourself has been disabled for the session. We do want to capture all your questions using the Q&A button at the bottom of your Zoom screen. So if you're new to Zoom or you're new to the AME Grand Rounds, if you'll take a minute to familiarize yourself with the screen, at the bottom of your Zoom screen, you should have a button that says Q&A. If you don't see it, you probably have a option that says more with an ellipses, the three little dots. If you click on that more, you'll find Q&A there. So if you want to enter in a question, that's how you're going to enter it. And that way we can answer it for all the participants. Also, I would ask that you limit your questions to the topics being discussed. There's always lots and lots of things that you could ask the FAA, but we do want to limit the Q&A for the AME Grand Round session to those topics we're discussing today. Also, as part of our accreditation, we do have to disclose if we have any prohibited relationships for any of our speakers. And this is our statement for this session, that no speakers have any prohibited relationships to disclose. CME, that's always a question. How do I get CME? We do give 1 hour of free CME for attending the Grand Round session. If you will right now take a look at your screen, find yourself on the screen and look and see what your name is as it's listed on Zoom. We can only grant CME credit to anyone that has their full first and last name displayed. We cannot and will not grant credit if you are listed as iPhone or iPad or admin office or Bob's Burgers or whatever it happens to be. Make sure that your name is displayed on the screen. If it needs to be changed, if you'll find yourself in that window, click the three ellipses in the top right-hand corner and then click on rename. That will allow you to rename your name and place it as your first and last name. And that's all a part of our accreditation. Also, if you are watching this recording at a later date, we appreciate the time that you're taking to watch the recording. However, we cannot grant CME for watching the recording. Now, here is the process to request your CME. We've done this for a few months now, and it's worked very, very well, and we've had a lot of great feedback. Linda's going to drop in the chat the link to request CME. It is a tiny URL, and it's https://tinyurl.com/OCT Grand Rounds CME, and you should be able to see that on your screen. We've also included a QR code on the slide in front of you. So if you'll take your cell phone, your iPad, whatever you might have that has a camera, and point that at the screen, you should be able to follow that QR code. Now, keep in mind that QR code and that link change every single month, and it will close about 48 hours after this session. So following the session today, I would like to encourage you to go ahead and request that CME. Don't wait to do it, because it will close on Friday, and after that you won't be able to request the hour of credit. Also, the QR code and the link change every single month, so don't try to save that as a bookmark, because it won't be good after Friday. Thank you. Next slide. Our objectives for this session are twofold. We're going to first discuss loss of consciousness as it relates to neurological issues, and then we're also going to discuss the STEMI, STEMI, FAA required follow-up for cardiac. And with that, I'm going to go ahead and turn this over to Dr. Roger Hesselbrock, who is one of our neurologists. Dr. Hesselbrock.
Good morning, good afternoon, everyone. Coming to you from now very sunny Hollywood, Maryland, just south of DC area on the Chesapeake Bay area. So we're going to talk to you, actually I'm going to focus on severe traumatic brain injury, not just loss of consciousness in general, but severe TBI. Dr. Wyrick, the Deputy Federal Air Surgeon, asked that we address that because we tend to get a lot of questions about why we request a certain observation time for certain severities of injuries. So we'll go into that as we cover the slides here. Next slide, please. So we'll do a little bit of background here. Hopefully you all are familiar with navigating the information that's available here. But to get to the AME guide, you can go online and you can drill down and search for neurologic dispositions, conditions, and find them that way. Next slide, please. And here we go again. You can look in the aeromedical disposition considerations by systems, and you have a tab section you can go for neurology conditions as well. Next, please. And under that, you have various conditions that can be looked at. If you want to know the requirements for a particular condition, you can click on that and you can get a PDF that will explain what are the current recommendations for requirements in evaluation and review of those particular conditions. So this just has A through C, but you can continue to drill down and hit the rest of them if you wish. Next slide, please. Another reminder slide here. There are some conditions in the nervous system that you as AMEs can issue potentially here. So if there's a remote minor head injury, no loss of consciousness, no amnesia, you can issue that. If you have a solitary fully explained syncopal event, you can issue that. If there is a solitary, meaning one-time childhood febrile seizure, you could issue that. If you have a headache that meets CACI criteria, you note that in block 60 and issue. Same thing with essential tremor. If it meets CACI criteria, you note that in block 60 and you enter that. And then if there's a condition that's been given a special issuance and then you've been delegated AASI authority for renewal, if that airman meets the AASI criteria that are specified, then you can note that and you can issue in that regard too. But it's very important as you go through that process that since you're on the front lines, you verify the clinical reports and records to satisfy yourself that it's indeed validated before you sign off. And if you're in doubt, call us for guidance or defer the case to us for further consideration. Next slide, please. All right, so these aren't all the same individual, thank goodness, on here, but this gives you an idea of some of the CT representations of different types of CT abnormalities in traumatic brain injury, ranging from diffuse swelling in the bottom right to an epidural hematoma on the top left. And it's not uncommon, you'll see combinations of these in a given individual. Next slide, please. So maybe when you see someone with head injury, is it just a head injury itself? Did they just knock their head, get a goose egg, have to have a few stitches, or did they actually injure their brain along with it as well? So if you look at our guide under head injury or brain injury, the head injury would mean no concussion, no brain injury, no neurologic symptoms. In other words, somebody who knocked their head and that's it basically. If that's all it is, you verify that, you can go ahead and issue those as well. You'll see at the bottom here, if there's, you kind of get into the column B1 here, there's an injury more than 5 years ago that's a concussion or a mild TBI, and you can satisfy yourself that that's all there is present and nothing more, then you can go and issue in that case, but pretty much everything else has to be deferred. Next slide, please. So these are our definitions that we use for severity, aeromedical severity of head injuries. So mild would be up to an hour of loss of consciousness, amnesia, or alteration of consciousness. And we would put concussion into that realm as well, too. And then moderates would be over an hour, but up to 24 hours, also with a non-depressed skull fracture, minimal subarachnoid hemorrhage, minimal tentorial or falcine subdural hematoma. And then severe would be other types of intracranial bleeding, a depressed skull fracture, or alteration or loss of consciousness 24 hours or more. Next slide, please. Okay, so just a conglomerate case out of recent experience here. So let's say you're seeing a young woman who's a first-class applicant who reports an admission to the hospital 6 years previously about for a minor accident with a minor injury, no sequelae, and they get issued. And then fast forward to February of this year, they note that there's minor injury, brief loss of consciousness, and it's documented minor concussion, previously reported no complications or issues. And the case comes up with us for an internal review in April of 25, and records from that 2018 encounter were requested. Next slide, please. And lo and behold, when we get those records, this happened while the individual was in the Netherlands, so they had to be translated. But apparently, the individual was in a bar, injured themselves falling off a bar stool. They were out for a few minutes. They were confused with EMT when EMS arrived. And no kidding, they had a blood alcohol of 0.443. And a CT scan was read as showing intraparenchymal hemorrhage with the small amounts of subarachnoid and subdural hematoma. And the individual got admitted to the ICU initially, had EEG monitoring, did not require neurosurgical intervention, but was discharged 3 days later in stable condition. And that's what we found when we reviewed. So this individual that didn't disclose all of this initially was certificated. If we had known that going in, they would not have been initially certificated, but then we have to go back after the fact and potentially request some new information based on what we have here, not only for the head injury standpoint, but also they had an alcohol level that would put me in the ground 6 feet under if I had that level now. So we have to address that too, unfortunately. Next slide. This is just to point out that we need to trust but verify, the old slide with Reagan and Gorbachev here, that we don't see the airmen face to face at FAA. you do. We do get the clinical notes when we request them, and we oftentimes will need to get the reports from the initial presentation because the history, unfortunately, may change over a period of time as well. So that's just to illustrate the need to not only trust but verify what's going on before you sign off on here as well. And we do have a QA process in FAA, so we don't look at every case, but some get pulled. And if we do find discrepancies like this, we'll address them as they come up. Next slide, please. All right, let's get back to TBI here. So what do we worry about? The here and now. What's the neurologic deficits? What sort of cognitive deficits might they have? Generally, these increase with the level of severity of the injury, but sometimes there are discrepancies between the seemingly mild presentation and what you might find on imaging findings as well too. So that's the here and now. What do we worry about for the future? The big thing is the risk for seizures and development of recurrent seizures or post-traumatic epilepsy. And that's what drives a lot of the recommendation for recommended observation time after head injury. Now, thankfully, the epilepsy risk, seizure risk does decline over time. We'll show you a couple of graphs here from different studies, and you get the greatest decline within about 2 years after injury, a lot of it within about 5 years of injury, but as you'll see, the risk with severe injuries remains elevated many, many years after the injury. And it's not uncommon. You'll see anecdotal reports of individuals that have had a head injury and many years later come up with a seizure. Now, if it's 20 years after an injury, it may be very difficult to tie that in directly, but at least there's a theoretical possibility for it. Next slide. We'll show you that in some of the graphs here. So this is the seminal study from Anigers and Hauser et al. From the late 1990s, that looked at head injury severity and probability of seizures. And you can see the severe, that's got the little squares on it here. You can see there's a risk that jumps up pretty precipitously over the first year or so. And then when you get to about 5 years, you're about a 2% per year average on here. Goes up a little bit more between years 5 and 10. Does continue to go up though. And although it's not anywhere near as steep of a curve after you get to about the 10-year point here. So what we really want to focus on is this first interval. So this is where our initial guidance of 5 years after severe head injury came from, was the seminal studies of Anigers. Next slide, please. Okay, this is another look from a study that looked at risk of epilepsy. Now, epilepsy means recurrent seizures, so this is maybe a little bit different than just your isolated seizure. But again, you can see that by severity here, and it may be a little bit hard to look at here, the risk does go up, but it does tend to level off a little bit as you get up to that 5-year point or later. And this was from 2021. Next slide, please. And then this is a more recent study out of Annals of Neurology from 2022. It's a little bit different representation, but you look at the red line, that is the time to first seizure, probability to first seizure. And again, you see a lot of it, you get the steepest amount within about the first year or so. You get up to year 5, it really starts to flatten out a lot. It doesn't totally flatten out, but you get not a whole lot of extra increase after year 5. So many times we'll get questions, well, why is FAA using 1990s data when they're making these recommendations? Get with the program, FAA. Well, it's interesting that the newer studies that have come out that are incorporating the more modern imaging techniques that Anigers did not have available in the late 1990s, that pretty much corroborates what that seminal data showed. Now, there are other studies that are ongoing. Some of my former colleagues at the School of Aerospace Medicine at Wright-Patterson are looking at TBI and seizures within the Air Force population, but those results have not been published yet, and we don't know how much applicability that'll have to the civil aviation population, but we'll be keen to look at those results when those are published. Next slide, please. So this is how we incorporate some of this information into observation periods. So if you have the minor head injury, no TBI, no concussion, like we said before in the AME guide slide, you can issue those certificates when they're fully recovered. And if it's over 5 years ago, you can do that as well. If there's a mild TBI, and this would include the concussion, assuming that they're fully recovered from it, we have a 6-month recommended waiting period. And many times people who have had concussions will not resolve their symptoms for several weeks afterwards and sometimes several months afterwards. So that allows time for them to heal up and get all these symptoms out of the way before certification consideration. Next slide, please. Now for moderates, we used to have a 2-year wait at least for that. We've narrowed that down to at least 12 months in this case. So if you remember that, the people who have very minor subarachnoid hemorrhage or a small falcine or tentorial subdural hematoma, those would be considered at the 1-year standpoint, assuming everything else is going well. Severe, we're leaving it at the 5-year standpoint for now. We do have some capacity for earlier reconsideration on a case-by-case basis, but within reason. So if it's truly a severe head injury and it's submitted at 1 year, we'll look at it, but we're going to say we need to wait longer period of time. If it's somebody that's a 4-year standpoint, we may look at that on a case-by-case basis through our formal neurology panel. But in most cases, we'll want to wait that full 5 years, allow the brain to heal, and let that seizure risk to decrease as much as possible there. Now, in cases of a head injury that would have an early seizure, early defined within the first week after injury, we defer those for at least a couple of years, even though that's considered a provoked seizure. That does have a risk of having a recurrence, although not as high as an unprovoked seizure. If you have what's called a late seizure, 1 week or more after the injury, unfortunately, those have pretty much the same risk of a second seizure as an unprovoked seizure. And we would put that in the same category as an unprovoked seizure in adults, which would be a 4-year observation period for those cases. So you have to factor in if seizures present, does that impact, no pun intended, the observation period that you need to do as well. Next slide. So a lot of material here, but you see head injuries. They're not uncommon. They're out there. Unfortunately, each one is unique. And I would tell people at the flight surgeon training, the AME training, if you've seen one head injury, you've seen one head injury. So every one is unique. You have to look at it on its own merits on a case-by-case basis. So our aviation risks are both with the sudden incapacitation related to seizures, and also maybe more subtle incapacitation, cognitive effects, which may or may not be apparent in your day-to-day office conversation with the airman. You're at the front lines as AMEs to help guide the airmen through the AME guide and other resources to get the accurate documentation and submit that up for us to take a look at, either at the AMCD level at Oklahoma or the FAST level that we're at as an addition. So the history is the big thing, especially in neurology, and you're its linchpin for gathering here.
Greetings, yeah, Dr. Bendrick here, Greg Bendrick, coming to you from Civil Aerospace Medical Institute here in Oklahoma City. It's a bright and sunny day, and we're warming up. We were a little bit cooler this week, but we're warming up, so that's good. And a lot of you, I think, have heard me talk before, just by way of introduction. It came through the Air Force, did Air Force for a little over 9 years. Did the residency in aerospace medicine as well as the residency in occupational medicine. Got out, did 3 years in the private sector down in New Orleans as an occupational medicine specialist, and then took a position with NASA out in California on Edwards Air Force Base at the NASA Dryden Flight Research Center for the next 16 years. And then in 2017, came here to the FAA here in Oklahoma City, and I've been here ever since then. currently a medical officer here in the aeromedical certification division, and as of the last year, became the official training medical officer for physician training and doing a lot of the QA that Roger and Ronan had mentioned. Anyway, Dr. Wyrick had requested that we clarify once again what our FAA requirement is for pilots who've had ST elevated myocardial infarctions. And for that matter, I mean, for the record, our follow-up is going to be the same if you had a non-STEMI or if you've gotten your coronary artery disease revascularized for whatever reason. Usually it's for either non-STEMI or a STEMI. But we'll address it specifically as STEMI and move on from there. So next slide, please. So as was mentioned with the neurology workflow, in the cardiology side, we have some waiting periods, especially, well, particularly for the first and second class pilots. If they've gotten stents, doesn't matter how many stents they've gotten, but if it's stents and not a CABG, then we require them to wait a minimum of 3 months after their intervention, after their diagnosis, whatever, to before we'll get the follow-on requirements, which we'll talk about, and assess them at that point. If they get surgical bypass, or in some cases, now they're starting to do this minimally invasive surgery, particularly for a one vessel bypass of the left anterior descending. I've seen a couple of those cases. We treat those the same as open surgical cases. And for the coronary artery bypass grafts or the CABG, that's a 6-month downtime, wait time. And that has been looked at in recent years. Specifically in March of 2024, we had a cardiac roundtable here in Oklahoma City, where we looked specifically at these requirements, particularly at the requirement for a post-event cardiac catheterization, cardiac angiogram, which I'll talk about here in just a minute. And those requirements for the initial certification, based on their review of the available data. In some cases, there wasn't much. In other cases, there was. And expert opinion on these cardiologists, all of whom are true aviation cardiologists. And so we still recommend for the CABG a 6-month waiting period. And likewise for a left main stent, that's a 6-month waiting period. Most of you know, normally if you have a high-grade lesion in the left main artery, that's an indication for a coronary artery bypass graft procedure. In recent years, we have seen in some cases where they'll go ahead and put a stent there in the left main. But in those cases, we require them to wait 6 months, and they will all be reviewed by the cardiac panel. Now, having said that, for third-class pilots, when the basic med legislation came in 2017, part of that legislation, as part of that law, is that the FAA will mandate no required waiting period for third-class medical examinations. And it's like, okay, that's fine. We will follow the law, but we do request a statement from their treating physician, in this case the treating cardiologist, that they are cleared to resume full duties. And if they've gone through a cardiac rehab program, usually that's not a problem, and usually it's going to be about 3 months anyway at that point. But even if they haven't gone through a cardiac rehab program, we really want that statement from the treating cardiologist. And if we don't have some assurance that their activity level is okay, we may be asking for further information, which will push it past 3 months or 6 months after a CABG anyway. So, as was mentioned with neurology, they have a formal neurology panel that meets every so often here in Oklahoma City at CAMI. We have a cardiac panel which meets every other month. here in Oklahoma City, and we'll actually look at the imaging from the cardiac catheterizations as well as the nuclear, what they call the splash imaging for the exercise nuclear stress test. And I'll talk a little bit about that more here in just a minute. But all first and second class pilots are reviewed by panel. Now, why is that? Well, let's step back for a second and remember that, by federal law, Title 14 of Code of Federal Regulations, Part 67, the 100, 200, or 300 series, depending on whether you're first, second, or third class, they state, or the law states that if you have a history of angina, angina pectoris, coronary heart disease that has been symptomatic or is clinically significant, if you've had coronary heart disease that's required treatment, and for the record, if you've also had a pacemaker, a valve replacement, or a heart transplant, these conditions are specifically disqualifying by law. And even if you develop one of the conditions and somebody, typically a third class, wants to go basic med, those are still one of those listed conditions that they have to get an updated one-time special issuance from the FAA before they're eligible to go basic med once again. So this is written in the Code of Federal Regulations, literally. And so if the FAA, and namely, Federal Air Surgeon, is going to do something that public law says they cannot do, then we have to have a fairly clear process about how we're going to do that in order to give a special issuance, which of course the law says we can do. And so over many years, and as I mentioned, this was most recently updated by Cardiac Roundtable in April of 2024, and those updated recommendations were approved by the Federal Air Surgeon, and were all written up and everything and put into official policy guidance in May of 2024. But these, many years of dealing with coronary heart disease, and so there's still all first and second classes all have to be reviewed by the cardiac panel. Now, we will not routinely send third class cases, STEMI cases or non-STEMI for that matter, to the panel, but these applications are still reviewed by an FAA medical officer. And there are some cases, we provide individualized assessment, so there are some cases where we will need them reviewed by the cardiac panel, and we will request the imaging in that case. And I'll talk about that here in just a little bit. Next slide, please. So what do we need? So your pilot comes in and it's like, yeah, doc, I had, they called it a STEMI. I went to the ER. I had this crushing substernal chest pain after I worked out at the gym, and I went back to the hotel room and I took some Motrin and I drank some beer, and that didn't make it go any better. And since I had a show time of 5 o'clock the next morning, I figured I'd better go get it checked out. And the next thing you know, they were having their anterior STEMI, and they get whisked off to the cath lab and get their stent or stents, and now they're in your office. So what do we need? Well, we want the hospital records of what happened. As Roger mentioned, a lot of times what the pilot reports, and they're not lying. I mean, well, most of the time they're not lying. They're telling it as best they can, but they're not medical people and they don't know all the ins and outs and stuff. And so a lot of times things get distorted or just outright wrong. And so we want the hospital records. We want to know kind of what happened. How did they present to medical attention? Particularly were they in VFib, cardiac arrest, requiring bystander CPR? And if that's the case, we want to know, well, how long was the CPR? Do we need to worry about a potential, anoxic brain injury as a result of that? But we want to know that if nothing else, it's always good to get the hospital discharge summary, but I hesitate to ask for that because inevitably what we get are the hospital discharge instructions to the pilot. And the instructions don't do us any good. We need the discharge summary. So I've just, just when I'm talking to AMEs on the phone or whatever, it's like we want all the hospital records. Yeah, all 183 EMR pages of it. Specifically, we want that cath report when they go in to the cardiac cath lab. We want that report. We don't want the summary. We don't want, the cardiologist note afterwards about what they did. We want the actual cath report to see exactly what they found. What was the intervention? What sort of stents do they put in? Nowadays, they're almost always drug-eluting stents, but what sort of stents they put in? How big? How long were they? And also, what was the residual disease that they noted at the time that at least at that time, they did not address? And maybe they didn't feel it needed to be addressed, or maybe it was, because they were literally too busy trying to save the pilot's life that they figured they'd deal with the 80% RCA lesion later and stuff. Okay, well, it's good that they did what they did, but we want to know that. And for any first or second class pilot, when they've had a cardiac intervention like this, yes, we want the imaging, and the imaging must be submitted on disk, and it must be in the DICOM format. That's the common shared format. We have the readers for that. The FAA does not have the ability to get the proprietary readers that a lot of the healthcare systems use for their system, but they are required to be able to put things in DICOM format, and that's what we use. So one day we're hoping that we will have a medical imaging server here where pilots or AMEs could upload the imaging directly to the server from their computer. Obviously, there are all sorts of cybersecurity issues aside from the technical issues and the privacy issues that are required with that. And the FAA is working through those, but we have been, I guess I'm not out of line to say money has exchanged hands from the government to a contracted entity, and they've been working very hard with their people, and our people have been working to try to make that a reality. Of course, they haven't been working during the furlough, but hopefully they'll get back to doing that. And hopefully one day, basically, we hope to have a medical imaging server. At this point, we don't. So we need the imaging on disk. Some healthcare systems say, well, we don't do disks anymore. Well, I'm sorry. We're not going to be able to give that pilot a certificate. Usually when push comes to shove, somebody can go and find a disk machine and record it on disk. Now, for first and second class pilots, we also require, the FAA requires, after the waiting period, remember 3 months for stent, 6 months for CABG, we require a post-event cardiac catheterization, an angiogram, cardiac angiogram. That is not the clinical standard of care for practice in cardiology cases. But we're not practicing clinical care here. We're not treating disease that has been brought to medical attention by a patient. We're taking a patient, a quote unquote, a pilot, and trying to predict whether they will have symptoms or specifically a subtle incapacitation over the next year or so. So we're doing things, this is different from what clinical medicine is all about. And so, yes, for aeromedical risk assessment, we require a post-event cath. This was the main question that was the center of our cardiac roundtable in March of 2024. And after some extensive discussion, the answer, again, was that yes, for aeromedical risk assessment, we have to have a post-event cardiac cath. And ironically, just as an aside, we'll sometimes see, suspicious lesions or problems on the event cath, and then we get an exercise nuclear stress test with imaging that is questionable, and probably at least half the time, maybe more, The post-event cath actually gives us the ability to issue a pilot a special issuance, where otherwise we would end up having to deny and request further information like a post-event cath. So in any case, we do request a post-event cath. We require a post-event cath. Sometimes I'll have cardiologists that they'll get their permission from the pilot to talk to us, and that'll be sent in, and they'll call on the physician of the day, and I've had one say, well, doing a cardiac cath post-event when there's no indication, that would be malpractice. And I would say, well, I'm not a cardiologist. I'm not going to argue that fact. All I can do is tell you that we're not going to give them a certificate. And if it will help you, we will send a denial. You have your permission here to release information. We will send you a copy of the denial letter with the reconsideration information on it. And when that occurred, then the pilot was able to get his cardiac cath. So, I get it. The cardiologists are worried about medical liability. They're also dealing with insurance companies that at first glance don't want to pay for a cath when it's not felt to be clinically indicated. But at the end of the day, the FAA requires this. Likewise, we need after the waiting period, again, 3 months for stents, 6 months for CABG, for class 1 and 2 pilots, a post-event nuclear stress test. We call it a radionuclide stress test, an RS. Okay, it's a nuclear exercise stress test. Unless there's a specific reason why they have to do the vasodilator test, the Lexiscan, we really, really want them to do an exercise stress test, because the exercise is also a functional capacity evaluation. It tells us, how well they're doing. Can they go 9 minutes on a Bruce protocol? And so, of course, like with any stress test, we want the electrical tracings. And we want this, as I call it, the splash imaging. That is the sheet where it has the computer generated, the comparison of rest, stress, multi-slice, the short axis, long axis, and vertical, long, vertical, short, and the short axis, to look at the heart from 3 different angles, all put together on one sheet. That's the splash imaging. I don't know why they call it splash, but that's the setting apparently on the machine. Now, what we see a lot of times, and this is a problem that causes a lot of frustration for all of us, not the least of which is the pilot. And that is, they go to the hospital, they said, I got a letter here. I had my stress test, 3.5 months after my ER visit for my heart attack. I need the nuclear imaging on the disc. And so the technician looks at that and they go, oh, okay, you need the nuclear. So they put the imaging on the disc and we get it. And it's the raw imaging from that nuclear stress test. The raw imaging doesn't do us any good. We got to have that splash imaging. And so apparently when they download that file, it's a separate file in these imaging systems for the hospital. It's a different file, and that has to be downloaded separately. And so unless that is done, then we say, well, we can't take your case to panel because we have to have the splash imaging. So I ask now, and it goes out in our letters, that we want that splash imaging on both paper and disc. We like it here on disc because it's much more detailed. You can blow it up. It's a much better quality image. We will accept a paper only reading if it's legible, if it's not been Xeroxed 10 times and we can't even read the thing. But you think I'm joking? But we will accept the print, preferably a color print. And so we're now requiring those on both paper on this. The reason is, if you go to the pilot goes to the medical records technician there at the hospital and they say, okay, I got to have it on both paper and disc. They're going to look with this, questioning look and say, paper? Oh, you must want the splash imaging. Yes, like it says in the letter, we want the splash imaging. And when we do that, we're more likely to actually get it. And if we only get it on paper, that's fine. We'll take it. We won't hold it up for that. But usually we get it on both paper and disc, which is ideal. Of course, we'll need also a current cardiologist office note. After the waiting period, 3 months or 6 months, we need a current office note addressing the functional status. And we'd love to see when they say something like, I have no concerns whatsoever about this pilot returning to the cockpit and flying an airplane. That tells us they're very confident in this pilot and their cardiac status. We'd like to see that. And then, of course, we need current labs for risk assessment, namely a lipid profile and an A1C level. I know, even if they don't have diabetes, we still want the A1C level. It's a risk factor for coronary artery disease. In the future here, we may be looking at lipoprotein A levels. Okay, don't take that home. Don't write that down. There's ongoing studies. There's medications apparently that are being developed. But if and when that comes, we'll look at that. But for right now, it's a lipid profile, namely the LDL level and the A1C level. Next slide, please. So, couple things. Even third class, if they're left main stent, they're going to go to panel. The limited second and the third class left main stents, they don't have to have a post-event cardiac cath, but the limited second class, they still have to have an exercise nuclear stress test. The limited second class, that's if they're an agricultural pilot or flying as a part of a two-person crew, or if they're a flight engineer and that sort of stuff, which are very rare nowadays. But those are the limited second class. We're not seeing a whole lot of those, but they don't have to have a post-event cath, but they do have to have an exercise nuclear stress test. And if they're a left main stent, they have to go to panel. Otherwise, they don't have to go to panel. Same way with third class, they don't have to have a nuclear stress test. But if the plain stress test is not interpretable, we will request a nuclear stress test. Now, as I mentioned, the third class won't go unless they've had a left main stent, or if there's untreated coronary artery stenosis we see on their event cath that's more than 70%, or they did an IFR or FFR, fractional flow reserve, that indicates that lesion is obstructive. Even if they're not reporting any symptoms, we're going to bring that one to panel. We're going to have our cardiologist look at it, and we may be denying them and requesting a repeat cardiac cath because of the risk of this becoming obstructive in flight over the next year. Anyway, next slide, please.
And Dr. Bendrick, just to let you know, we only have about 5 minutes left, and there's quite a few questions.
Oh, my goodness. Okay. So we'll wrap this up then. As a result of that cardiac panel, we found that review of the literature that routine stress testing for these pilots is really not indicated anymore. It's really all about risk factor management. So we put together this coronary artery disease risk factor research status summary. So normally we won't be requesting ongoing stress testing. It's really just looking at the risk factors, blood pressure, functional status, LDL, and A1C. We still need the A1C every year, even if they're not diabetic. Now, if their risk factors are not controlled for whatever reason, a lot of pilots just don't want to take statins because that's the way they are. They don't have any side effects. They just want to take them. Well, that's fine. Then in that case, we are worried about progression of disease, and we will be requesting annual stress testing of one sort or another. Anyway, that's all I have, and I think we're at the end of our time, and so I'll shut up now.
Thank you, Dr. Bendrick. I always learn something new, and I know our AMEs do as well. On the screen is a email address. This is just a shameless plug. If you have suggestions for AME guide improvement, you can send it to AME guide all together at FAA.gov. Keep in mind that this email inbox does not answer any case questions. Also, at the top of the hour, we talked about how to grant or how to request your CME credit. We had several participants that did not change their names from their iPad or iPhone. And just a reminder, we can only grant CME if you had your full first and last name displayed throughout the session. but I do have the QR code back on the screen, and Linda will put that URL in the chat as well if you'd like to just copy that or use your camera to go and request CME for this session. We will be repeating this session again this evening Oklahoma time at 1900 or 7 p.m. Central Standard Time. And that's all we have for this session. Thank you so much, and thank you for attending, and thank you for your interest in aviation safety.